since last 1 week, we have completed all the cardiac arrest algorithms and post-cardiac arrest algorithm. Now, the next thing that we have to discuss is how will you tackle when a patient is coming with arrhythmias. So, arrhythmias again, it can be of either bradyarrhythmia or it can be tachyarrhythmias. So, what is arrhythmia? Arrhythmia is abnormal beating of the heart. That is a basic thing. So, normally when it is beat, we'll call it as normal sinus rhythm. So, whenever it is not normal sinus rhythm, we can call it as an arrhythmia. So, suppose an ectopic, you can call it as an arrhythmia. Suppose there is a tachycardia, you can call it as an arrhythmia. If there is a bradycardia, you can call it as an arrhythmia. So, anything that is not normal, we can call it as an arrhythmia. So, basically, arrhythmia is divided into two types. One is tachyarrhythmia, that is tachycardias, and bradyarrhythmias. So today what we'll going to discuss is approach to a patient that who has got a bradycardia. See, when we discuss regarding bradycardia, what we know that bradycardia is heart rate less than what? Heart rate less than 60 beats per minute is what we have learned. For the algorithm purpose, what they have defined, the algorithm, this is for just this algorithm, AH algorithm, anything less than 50, we can call it as bradycardia. Anything heart rate less than 50, we can call it as bradycardia. See, in any arrhythmia, for that reason, whether it is bradycardia or tachycardia, we will use two terminologies. One is stable and other one is unstable. Unstable is what we use for tachycardias. So, whenever you call it a tachycardia, it can be either stable or unstable. And in bradycardia, we call it as symptomatic and asymptomatic. Symptomatic and asymptomatic. The patient is not having any symptom, and here the patient is having some symptoms. So these are the two things that we use. So bradycardia, we call it as whether the bradycardia is symptomatic, and tachycardia we will tell it as whether it is stable or unstable. So for this purpose, what we are going to see is having wherever we are using this terminology, stable or unstable or symptomatic or asymptomatic, what we are trying to see is here organ perfusion. Suppose heart rate is low. So what will happen to the organ perfusion? It will also decrease. So what will happen when there is a decrease to the organ perfusion to the brain? The patient will have altered mental status. So when there is again decreasing in blood pressure, decreasing in blood flow, again what can happen? There can be hypotension. When there is decrease in blood supply to the coronaries, there can be chest pain. So what we call it as an unstable signs is basically that organ perfusion is affected. So which organ perfusion? Either it is the heart, or it is to the circulatory failure, or it is to the brain. So these are the basic things that you need to remember. So whenever a patient is coming with, suppose a patient is coming with a heart rate of 160 and is having a chest pain. So that means it is an unstable tachycardia. You are seeing a patient with heart rate of 160 and the patient don't have any symptoms of decreased organ perfusion. He don't have any hypotension. He don't have any altered sensorium. He don't have any chest pain or breathlessness. Then we can call it as it is a stable tachycardia. So similarly in bradycardia, when the patient is having no symptom, we can call it as asymptomatic bradycardia. And when the patient is having any symptom due to decreased organ perfusion, suppose there is giddiness. Why there is giddiness? Because of decreased organ perfusion to the brain. Suppose the patient had a syncope episode, suddenly he collapsed. So that is again symptomatic bradycardia. So our idea is to see whether the organ perfusion is affected or whether the organ perfusion is normal. See, when the heart rate is less than 50, what could be the reasons of a heart rate less than 50? What are the common causes for bradycardia? You can, whenever you discuss bradycardia, you can remember it can be physiological. There can be certain due to physiological reasons. What are the common physiological reasons to have bradycardia? One physiological reason can you tell? An athlete, a sportsman or an athlete who is regularly having exerting and he is having exercise. So he will be always having a lower heart rate. So athletes or those who is a sports person who is regularly maybe a manual laborer who is doing unloading, loading, unloading job. So they will have always maybe the heart rate might be on the lower side. But that heart rate because of the lower side they don't have any symptoms. They are able to do their daily routine activities. So that is an asymptomatic bradycardia. So one of the common reasons, physiological reasons, is athlete. And what are the other pathological reasons that you can think of whenever we call it as bradycardia? What are the common causes for bradycardia? Can you just tell me what are the most common causes that we will see? Most common causes for bradycardia. One is myocardial infarction. So myocardial infarction, suppose, which is your pacemaker of the heart? SA node. SA node is the pacemaker of the heart. Suppose the blood supply to SA node is disrupted. What will happen? The heart rate will slow down. So the patient can have bradycardia. So that is one myocardial infarction. Next, myocarditis. Any carditis or myocarditis, they can have any inflammation to the heart or inflammation to the SA node. It can cause both tachycardia and bradycardia. It can cause both. Then what could be the other reason? Abnormal functioning of the SA node or an AV node, because as age progress, the sinus node can dysfunction. So that is otherwise called as sixth sinus syndrome or sinus node dysfunction. So sixth sinus syndrome. So that is the other reason, because of aging. Just like our all organs, SA node also can have trouble. So that can lead on to sixth sinus syndrome and complete heart block. Then what could be the other reasons? What could be the other reasons there is a bradycardia? Pericarditis, pericardial effusion, all these things we have explained. Then what could be the other? Some drugs. The patient is on already on some drugs. Example, beta blockers, calcium channel blockers, digoxin. These are all drugs that can cause bradycardia. So the patient is already on any of these drugs, they can already have a lower heart rate. So bradycardia can be a possibility due to that. And if the patient is having an overdose, they have taken a lot of tablets and they have come to you, then also they can have this bradycardia and resulting in symptoms. So that is the reasons that you need to remember. What are the other causes that you can remember? Hyperkalemia. Again, hyperkalemia, what we have discussed initially, they can have tall T wave, then they can have SA, that PR interval prolongation, then sine wave pattern, bradycardia. Again, they can have bradycardia, then going on to tachyarrhythmias. Hyperkalemia. Then what else? Hypokalemia can have bradycardia. Hypothyroidism, that is another common cause for bradycardia, is hypothyroidism. Hypothyroidism. So these are some of the common causes. I am not saying the all causes. These are some of the common causes for your bradycardia. Suppose you are seeing a bradycardia patient, you have to think why he is having a bradycardia, or usually what will happen in an hypotension, what will be the body response? Usually when you have a hypotension, what will be the body response? There will be tachycardia. That is a usual response. Bradycardia usually seen, tachycardia is the what usually you see when there is having low blood pressure. So you have decreased BP, you can have increase in the heart rate. So why there is an increase in heart rate? The heart rate is increased because the heart is trying to pump up more blood to maintain the demand. But there can be certain situation where there is decreased BP and decreased heart rate. Can you tell me one example? Neurogenic shock. Neurogenic shock. There is a type of shock that is neurogenic shock where there can be hypotension with bradycardia. Neurogenic shock. Then there is another reason. This is one combination that I have given you. Then I can give you another combination where you can see there is increased blood pressure and there is decreased heart rate. Where will you see this? Increased blood pressure and decreased heart rate. Where will you see? Where will you see this? Raised intracranial pressure. Raised intracranial pressure. You will see increased BP and decreased heart rate. So that is otherwise called as Cushing's reflex. So Cushing's reflex, or otherwise it is called as Cocker's Cushing's reflex. Cushing's reflex is basically increased BP with decreased heart rate that you will see in patient with raised intracranial pressure. So these are some of the common causes that you have to see when there is having a patient is having a bradycardia. Now just leave alone all these causes. Now our idea as per the AHA algorithm is here to see what to be done when you see a patient with bradycardia. That is pretty clear. So we have a patient whose heart rate is less than 50 breaths per minute, 50 beats per minute, less than 50 per minute. So look, identify and treat the underlying cause. You have to look why this patient is having a bradycardia. One most important other reason that I have missed is hypoxia. Is other most common cause for bradycardia. Hypoxia. Suppose there is a hypoxia, the first thing that you can have is a bradycardia. You can have desaturation, hypoxia, bradycardia. So hypoxia, you can have bradycardia. So we have to make sure that airway is protected and assisted breathing if needed, like back mask ventilation is given to this patient. So you are seeing it is not a cardiac arrest scenario. You have to be very clear. You are seeing a patient with bradycardia. What is the next thing that you need to do is that we have to see whether the patient is having airway patency, and if airway patency is needed, you have to do that. Oxygen to supplement if there is evidence of hypoxia, and connect to the cardiac monitors and all monitors. Connect to cardiac monitors, SpO2 monitor and blood pressure. Hemodynamic monitoring needed to be done. So these are the next thing that you need to do. And if no IV access, you have to get an IV access, put an IV access, then get a 12 lead ECG and see if there is any evidence of ST elevation MI. So as I told, ST elevation MI can cause bradycardia. It's not always tachycardia, because if the blood supply to the SA node and to the right ventricle and all those things, if a right coronary infarction is happening, you can have bradycardia and ST elevation in the ECG. So you have to look for, you have to take a 12 lead ECG and you see, you have to look for the cause, that is ST elevation MI, and also you have to consider hypoxia and toxicological cases. See, there are other lot of reasons why you can have bradycardia. One common drug that can cause bradycardia. Can you tell me another drug, toxin, that can cause bradycardia? One toxin that can cause bradycardia. We have discussed. Treatment is atropine. Organophosphorus. Organophosphorus. So that can cause bradycardia. Can you tell me other agent? Opioids. That also will cause bradycardia. So there are n number of drugs that can cause bradycardia, but the common two agents that you can remember is organophosphorus and opioids. So they can cause bradycardia. So what you have to see, you have a patient whose heart rate is less than 50 beats per minute. Check their airway breathing circulation, whether it is okay. Connect to them to a cardiac monitor, SpO2 and blood pressure monitoring, and see if there is hypoxia, start them on supplemental oxygen. If the patient is not breathing well, start him on assisted ventilation like back mask ventilation. The next thing what you need to do is that you take a 12 lead ECG and you rule out a ST elevation MI. So then the next thing what you have to decide is that whether the patient has taken any of the toxins that can attribute to this bradycardia. So that is the algorithm. So now we have done here till here. So we have supplemented the oxygen, but still the bradycardia is persisting. So we have supplemented, hypoxia was there, you have supplemented the oxygen, and you had initial assessment, there is no issue. And then next thing what you have to do, the bradycardia is persisting, then you have to see whether it is symptomatic, or whether I can call it as whether it is stable or unstable. So what are the signs? If there is evidence of hypotension, that is the first thing that you need to ask for. There is no hypotension, okay. Altered mental status. Altered mental status. Why altered mental status? Decreased perfusion to the brain. Any other signs of shock, like capillary refilling time, prolonged capillary refilling time. So that is one of the other sign of shock. Then ischemic chest discomfort. The patient is complaining of chest pain, centralized chest heaviness, like typically you see in myocardial infarction, and there is evidence of heart failure. What is heart failure? The patient will having breathlessness, and when you auscultate, there is bilateral crepitation. So this is the next thing that you need to do. So we had a patient with bradycardia, heart rate was less than 50, A, B, C done, connected to the monitor, you have looked for the toxicological causes, you are supplemented with oxygen, still the bradycardia is persisting. Then next thing you have to see whether the patient is stable, or otherwise we can call it as symptomatic or asymptomatic. The patient is stable. The on signs of what are things you need to do, you have to look for features of hypotension, then altered mental status, any other signs of shock, then chest pain, ischemic chest pain, and evidence of heart failure. If any of these things is there, then what you have to do, you have to give the drug of choice is atropine. Remember, the drug of choice is atropine. Atropine, what you have to give is 1 mg IV stat. So the problem with atropine is that what atropine is available is 1 ampule is 0.6 mg. So that is not, so 1 ampule is not sufficient. You have to give nearing 1.5 ampules. So the dose of atropine is 1 mg IV stat. So that is the first drug that you need to give. So if any of these things, not one or two, one is enough. Any one of these persistent bradycardia causes are there, you have to give first drug of choice is atropine, and you can give maximum dose of 3 mg. So you can give 3 doses, that is maximum, with a time duration of between 3 to 5 minutes. So first atropine you had given, and after 3 minutes you are reassessing the patient, still the patient is having bradycardia, you can repeat one more dose. Like that you can go for maximum 3 doses of 3 mg. That is the maximum dose of atropine. So that is the first agent that you need to give. Next thing what you have to say is that if the patient is having still persistent bradycardia, so you have given atropine and still the patient is having bradycardia, then there is something called as transcutaneous pacing. So that is the next thing that you can remember, something called as transcutaneous pacing. What is basically transcutaneous pacing means? You have a patient who is having bradycardia, you are given atropine, it is not working, you are given 3 doses of atropine, it is still not working. So what you have to do is that, what is basically meant by pacing? You have a heart chambers like this, right atrium, right ventricle, left atrium and left ventricle. So this is what usually you have the valves here, you have the valves here. So what you are doing basically in pacing, there are two types of pacing you have to remember. One is transcutaneous, that is over the skin you are keeping paddles. You have seen our AED paddles. Similarly, we are keeping an AED paddles and we are connecting to a pacing device and we are setting a heart rate. Okay, so I want to set a heart rate of 50. If the heart is not beating above 50 beats, the machine will recognize that and it will deliver a external pacing. Suppose I am setting as 40. So whenever the heartbeat goes below 40, the machine will deliver the pacing. Not shock, it will deliver the pacing. It is not shock here, it will deliver the pacing. So externally the SA node is not functioning well. So externally we have kept a pacing device where the heart is getting stimulated to pump. So that is what is external pacing. If you are doing it over the skins just like paddles, we can call it as transcutaneous pacing. Suppose you are passing a catheter through your vena cava, so through your internal jugular vein, and you are keeping a lead into the right ventricle. So a cable, basically it is a catheter we will pass through the internal jugular vein, which will go to the superior vena cava, through superior vena cava to the right atrium and to the base of the right ventricle. So that lead will go and stay here. Okay, and again this will be connected to an external device and we will give pacing. So it is more accurate. So that is called as transvenous pacing. So pacing is of two types. You can have transcutaneous pacing and transvenous pacing. But transvenous pacing takes time. You cannot do immediately. So for that purpose, what we can go ahead is the transcutaneous pacing, which we can do immediately. So if the pacing facility is available, we can go ahead with transcutaneous pacing. So first step, we are given atropine. If the atropine fails, you can go with transcutaneous pacing. And you have other two agents that you can try is, one is dopamine and epinephrine. These two things you can start as an infusion, not as boluses, you can start as infusion. So dose of dopamine is 5 to 20 microgram per kilogram per minute. So that is the dose of dopamine that you can start. Dopamine infusion, you can start 5 to 20 microgram per kilogram per minute, or else you can start epinephrine 2 to 10 microgram per minute. There is no kg here, you have to be very clear. So when you are giving epinephrine, there is no kg. When you are giving dopamine, it is 5 to 20 microgram per kilogram per minute. The other one is 2 to 10 microgram per minute. So that is the dose, and depending upon the patient's heart rate, suppose you start at 5 microgram per kilogram and you are not getting the expected heart rate, so you can increase your dopamine. So that is what, depending upon your required response, you can increase the dose of these drugs. And if still it fails, what you have to do? We have done atropine failed. What you did is transcutaneous pacing, or else if you don't have transcutaneous pacing, you can go for epinephrine or dopamine infusion. And finally, if everything fails, you have to do for is transvenous pacing. So that is what you need to remember. So causes, what I have said, we have already discussed the causes: myocardial infarction, drugs like beta blockers, calcium channel blockers, hypoxia, and electrolyte abnormality. So these are some of the common causes that you can remember. So this is what you have to do when the patient is having any signs of bradycardia or symptomatic bradycardia, or you can call it as an unstable bradycardia. If the patient doesn't have any of these things, just monitor and observe the patient. Don't do anything. No need of any drugs. Just monitor the patient and observe. Okay, you can see why the patient is having bradycardia. You can send for investigation. Maybe he is an athlete, or there is might be an hypothyroidism. So all those things you can go behind and you can find out why he's having bradycardia. So what you have to remember is that whenever you have a patient with bradycardia, heart rate less than 50, first thing you have to rule out is hypoxia, airway patency, the patient is breathing well, and next thing you have to do hemodynamic monitoring, take a 12-lead ECG and see how the patient is, and rule out the common toxicological causes. Common toxicological causes why the patient is having bradycardia. Next thing what you have to see whether the patient is having any of the signs of hypoperfusions like hypotension, any other signs of shock, chest pain, altered mental status, and evidence of heart failure. If this patient is having any of this one, first drug that you need to give is atropine. Atropine will increase the heart rate. So atropine 1 mg stat, maximum dose of 3 mg. You can give 3 to 5 minutes interval. You can give atropine, and the next thing, if it fails, the option is transcutaneous pacing. If transcutaneous pacing is not available, you can think of dopamine or epinephrine infusion. If both fails, you have to go for transvenous pacing, and you meanwhile you look for the causes why this patient is having bradycardia. So bradycardia algorithm is pretty simple. What you have to see, if the patient is symptoms or any signs of hypotension, organ perfusion less is there, then you have to give atropine. If the patient doesn't have any of these things, just observe and monitor the patient. So anytime the heart rate further drops, you reassess the patient. Reassess whether there is any hypotension, whether there is any other issue. Then if there is there, you go with this algorithm. Clear? Okay, thank you.